Let me introduce Dr. Sandesara to you. Dr. Chirag Sandesara is a cardiac electrophysiologist who practices here in Northern Virginia. He is a brilliant physician, a wonderful clinician, diagnostician, and a terrific person as well. He takes care of patients at Inova Alexandria, Fairfax, Fair Oaks, and Loudoun hospitals. He sees patients in several of the Virginia Heart electrophysiology offices and has a special interest in both atrial fibrillation and in the whole host of conduction system diseases that can occur in cardiology patients. Dr. Sandesara did his residency and internship at the Medical College of Wisconsin, where he then served as the chief resident. He completed both his cardiovascular and his clinical cardiac electrophysiology fellowships thereafter at the University of Iowa. I think, are you frozen? Oh dear.
Can you see me okay?
Well, there we go. You were frozen there, my friend.
Okay.
Are you back?
I am.
All right. That's okay. That was fun. That was interesting. We never a dull moment here.
Let's try again.
There we go. There we go. You're full screen and you're ready to go.
Okay, great. Thank you, Dr. Levy, for that kind introduction. Tonight, I wanted to first say thank you, everyone, for joining us. I wanted to give a discussion regarding where we've been with atrial fibrillation, that is the past, talk about where we are today with atrial fibrillation management, and talk a little bit about what the future of atrial fibrillation management will look like as well. We'll start off with the past first. We know the heart's electrical system has several different components, and I wanted to just briefly identify some areas of interest here. One is a sinoatrial node. This is an area here, as you can see in the right upper chamber. This is called the atrium. In the middle part of the heart is the AV node, and the bottom chamber has the His-Purkinje system. Electricity flows from top to bottom in the heart, and these are areas of interest for us because this is how electricity can work both normally and abnormally. Now, in the normal heart, you'll see here that electricity starts from top and works its way down. You have a one-to-one conduction here. This is what normal will look like. In terms of atrial fibrillation, this is a depiction of how electricity starts from the left side of the heart and then works its way to the right side and then to the bottom. But you can see this chaotic sort of circus-like movements that occur here. And this is the irregularity that causes what we feel when we have symptoms of atrial fibrillation. So a very irregular, very chaotic pattern. Now, in the normal heart, again, as I said before, electricity starts in the right atrium and works its way and spreads to the left atrium. In atrial fibrillation, it's very much of a circus movement. There is electricity both chambers of the heart. They both impinge upon the middle part here called, again, the AV node, which is sort of like our traffic light for our heart. And then conduction system cells then take the information and get to the ventricle. But in atrial fibrillation, this is extremely haphazard. And as you can see on the bottom here, there's a very irregular rhythm that occurs because of this. And on the left side here, you can see the very normal, regular rhythm. Let's talk about the definition of what atrial fibrillation is. It is an irregular, often rapid heart rhythm disorder. The upper chambers beat very chaotically and out of sync with the lower chambers. This occurs about 2 or 3% of time in the population. So about 2 or 3% of the entire population has atrial fibrillation. And the risk factors increase over time with age. Actually, over 33 million people worldwide have AFib currently. We expect those numbers to grow over time. And you may hear these terms in this presentation, and you may have heard these terms prior as well. Paroxysmal atrial fibrillation is any form of atrial fibrillation that comes and goes and terminates on its own without any intervention, that is medications, for example. Persistent atrial fibrillation is the type of atrial fibrillation you may have that lasts more than 7 days continuously. And we call permanent atrial fibrillation any form of AFib that continues, but we accept it. We don't treat it urgently, and we don't use advanced care. And we'll go over this later on in the talk, of course, as well. I talked about the prevalence of atrial fibrillation. You can see here worldwide what the prevalence is. It's mostly, it turns out, in Western nations. We see some of this also in South America starting to rise, and very few people in the East Asian locations tend to have atrial fibrillation. And we think a lot of this has to do with lifestyle risk factors, obesity being one of them, actually, and we'll go over that, of course, as well. And so this is a common problem throughout the world, but more so in the Western markets, such as the United States and North America, than it is sort of in the Eastern population of the world. As I said before, atrial fibrillation is a common problem as we age. Age is a risk factor, actually. And you can see here for both men and women, there tends to be a higher proportionate distribution of atrial fibrillation after age 60, up until age almost 90, 95, and it starts to reduce. But if you are in your 60s or 70s or 80s, the risk of atrial fibrillation starts increasing suddenly, and we'll talk about ways to try to prevent that from happening. So here's a depiction of what atrial flutter is. We're not going to talk about atrial flutter today, but I wanted to just mention this because atrial fibrillation and atrial flutter, I often call our cousin arrhythmias of each other. They're not necessarily the same rhythm, but they're somewhat related. As you can see here, atrial flutter occurs in the right atrium, whereas fibrillation occurred in the left atrium. Atypical forms of this arrhythmia can occur in the left atrium, however, and treatment is the same. We do basically the same treatment algorithms in terms of medications or catheter ablation, but the real estate, the geography, the location is completely distinct. What are some symptoms that you may have that could be potential signs or suggestions that you may have atrial fibrillation? Well, fatigue is the most common, but of course that's a very frequent symptom with a lot of heart problems. But then palpitations, skipping heartbeats, or racing heartbeats can oftentimes be a symptom. Dizziness, lightheadedness, chest discomfort, shortness of breath, or just feeling irregular heartbeat or an irregular pulse. These are all common symptoms we hear about with patients that have atrial fibrillation in our office. So oftentimes, however, patients may have no symptoms. You may have atrial fibrillation and may not be aware of it. And why is that? Well, sometimes people have regularity, but it's not extremely irregular. It may be mildly irregular. And oftentimes extremely well-conditioned people, such as athletes, for example, may not be aware of it. And so for all these reasons, being somewhat aware of what your heart rate is and your blood pressure, for example, is important because all of these things may sometimes show or give you clues towards atrial fibrillation. But what are some ways you can actually diagnose this or be aware of this? One of the potential applications of technology that has become much more commonplace now is these handheld monitors you can buy and purchase, or a watch potentially can do the same thing and can alert you to atrial fibrillation. And what it shows is a EKG tracing of what normal rhythm is. Basically, it takes a template when you first do it, but it also has its own template by algorithms such as using things like artificial intelligence. And then it can then register your irregularity and suggest that you may have, in fact, atrial fibrillation. But again, you have to show this to your physician and to make sure it is actually exactly what it shows, because sometimes there are false positives. On the lower left-hand panel, you can see a person wearing a monitor. These are oftentimes used in the office. We put patients through a Holter monitor or an event monitor. This also is a patch you wear. It is generally water resistant. You can wear it throughout the week and take it off. These last anywhere from a day to 30 days sometimes, and it also can help track and register atrial fibrillation. You may have heard of a cardioversion. This is something we do for patients that have had persistent atrial fibrillation, meaning they've been in it for more than a week or so. They're highly symptomatic. It is an outpatient procedure and it requires general anesthesia. And what happens here is you come into the hospital fasting. You take the medicines that we prescribe for you. Sometimes we give you advanced medicines to take to help maintain normal rhythm after the cardioversion. The medicines are there to help regulate your rhythm once the cardioversion is completed. But as you can see here, the EKG shows that there is an irregular rhythm. And then we attach a electrode or patches on the chest attached to a machine, and we can submit an electrical impulse by way of this machine to reset the heart's rhythm. And this is a very simple outpatient procedure, very safe, requires anticoagulation or blood thinners, and oftentimes your doctors will prescribe that at least for a few weeks before the procedure, sometimes even longer. And then afterwards, you should be able to maintain normal rhythm. Sometimes it doesn't work. Sometimes it may be an unsuccessful procedure. All of these things can document and dictate to us what the prognosis is for atrial fibrillation, meaning what is the severity of disease. So that's the past. Let's move on to the present. What do we know about what we're doing today for atrial fibrillation? Well, we know many risk factors exist that continue to affect your ability to maintain a normal, adequate quality of life with or without atrial fibrillation. For example, smoking or alcohol use, hypertension, diabetes, vascular disease, chronic kidney disease, obstructive sleep apnea. These are all known risk factors for not only heart disease, but also atrial fibrillation. And oftentimes we need to look at all of these individual risk factors and we talk about these things and ask about them as well, because some of these things, sometimes if they go untreated, will continue to perpetuate atrial fibrillation. I wanted to just touch base on alcohol because this is a common question that comes up frequently in the office setting for many of us that take care of patients with atrial fibrillation. Alcohol is a known risk factor for atrial fibrillation. Any amount of alcohol, unfortunately, is unsafe when it comes to atrial fibrillation. And this is a study done in Australia. Australians tend to drink a good amount of alcohol. They took a group of 140 people who drank more than 10 drinks a week. And they basically asked them to stop drinking for 6 months, and they had another group called the control group that they continued drinking. These are all patients that had a known history of atrial fibrillation, and just stopping alcohol itself cut down the relative risk of recurrence of atrial fibrillation in a 6-month follow-up. The control group continued to drink. They had a 1.2% atrial fibrillation risk over time, and the group that didn't drink cut that risk by more than half. And so very important, if you are having symptoms of atrial fibrillation and you do have 1 or 2 glasses maybe of wine a night or a few times a week, the American College of Cardiology, American Heart Association says it's best to cut that down as much as possible, maybe no more than 1 or 2 drinks a week. What about exercise? This is another common question I oftentimes hear in the office, is whether exercise is safe or harmful when it comes to atrial fibrillation. Well, this is a bit of a U-shaped curve in terms of just heart disease and also exercise in general. As you can see on the left-hand side, the patients that tend to be mostly sedentary, okay, tend to have actually less risk of diabetes, it turns out, or lower risk of heart disease when you start having a little bit of exercise. Now, if you go on to having a little bit more moderate exercise, such as bike riding or even running, you start increasing your coronary vascular reserve and increasing your functional capacity. But then when you start increasing your exercise capacity to things such as rowing or long distance biking or long distance running, marathon runners, for example, you start increasing the risk of heart disease. Atrial fibrillation is one of them. Whoops. And as you can see here, there's a 5-fold increase in patients with atrial fibrillation that go on to have a high amount of exercise capacity. And oftentimes, and there are studies for this, we tell patients that are exercising frequently for high levels of duration to decondition, to cut down the amount of exercise you're doing, because that tends to help reduce the risk of further atrial fibrillation going forward. Okay, what about stroke? This is a very important topic, and this is one of the most common feared risks from atrial fibrillation. This is actually one of the risks that increase mortality from atrial fibrillation, and we have to take it quite seriously. Many risk factors exist for stroke and atrial fibrillation, and the mechanism is basically when your heart is fibrillating, it is not pooling properly with blood. Blood tends to stay in a stasis manner or a non-mobile manner. And when blood coagulates in the atrium, particularly in an area called atrial appendage, it can potentially cause a clot. The clot can break off, go to your brain, and cause a stroke. Risk factors that lead to this include heart failure, high blood pressure, age over 65, but then if you're over age 75, you get actually a couple more points added on. Diabetics tend to have a higher risk. Of course, if you've had a stroke or a previous history of clots to your brain, that increases your risk. And then females tend to be at a higher risk than men. And as you can see on the right-hand side here, if you have none of these risk factors, your stroke risk still is low, very low at 0.2%. But if you have 3 or 4 risk factors, for example, or anything above 2, we tend to need an anticoagulant. 2 or more requires blood thinners for sure to help reduce the risk. As you can see, there's a marked difference between 1 risk factor to 2 risk factors. So if you have 2 or greater risk factors, you require a blood thinner. This helps reduce the risk of stroke going forward. These blood thinners that we now use, circled in red here as an outpatient, are quite safe. They're very effective. They reduce risk of stroke. They have very little in the way of bleeding complications. We used to use a drug called Coumadin. We still use that in some people. For example, if you have a mechanical valve or severe mitral valve disease, for example, Coumadin is the drug of choice. Another drug you may have heard of in the hospital setting is heparin or Lovenox. These medicines are also, they work very similarly to our oral medicines such as Pradaxa or Xarelto or Eliquis. Now, I want to talk about another area of interest, and this is called a Watchman device. This is a left atrial appendage occlusion device. As you can see in this cutout diagram animation, we can plant a small little device in your left atrial appendage through the leg. This is for prevention of clots to form, and this is another method that we can utilize to reduce the risk of stroke in patients that cannot be anticoagulated. And so what is the indication for a Watchman device? Well, if you have been considered to have atrial fibrillation and are certainly at an increased risk, but you have a contraindication, meaning you cannot be on a blood thinner, and what would that mean? That would mean you have a coagulopathy or a blood problem where you can bleed very easily, or you've had a bleeding complication on a blood thinner, such as bleeding in your urine, for example, or bleeding in your stool. You cannot be on a blood thinner based on your physician's recommendation, then consideration for a device like a Watchman implant would be reasonable. Moving forward to medications, we have several medications we use for atrial fibrillation. You may have heard of some of these beta blockers or calcium channel blockers such as diltiazem. These are common first-line agents to help control your heart rate. These are called rate-controlling drugs. And we use them for a variety of reasons in patients with hypertension or heart failure or even emphysema. Particular drugs can be used. They all help control the patient's heart rate. We have also a cadre of drugs we use that can help control your rhythm. Drugs such as dofetilide or dronedarone, flecainide, propafenone, sotalol, and amiodarone, all frequently used in patients for structural heart disease or even without structural heart disease. We have more particular drugs, but these medicines are quite frequently used, especially in the initial setting of a patient's first diagnosis of atrial fibrillation to help control the rhythm. But then certainly catheter ablation is part of that decision-making algorithm, and we'll talk about that here in a minute. And so what do we do when we see a patient that has atrial fibrillation, and how do we help manage this? Well, the indications for catheter ablation are quite simple. Anybody that has symptomatic atrial fibrillation meets criteria for a catheter ablation. Now, that wasn't true just about 5 years ago, maybe 10 years ago, but our technology is advanced now, and it's become much more frequent to move on to catheter ablation quite quickly instead of having to stay on medicines for prolonged periods of time. Drugs, by the way, have about a 50% efficacy, but there's also a 30% chance of side effects. And so this is not a great long-term choice. Sometimes we do need to use it for the long term in some people because of reasons that we can't do an ablation. The patient may be too sick, or they may have other comorbidities that prevent it from happening. And so we have several options here, but certainly consideration for ablation could be made as a first-line approach in many people that have atrial fibrillation. This is an animation that goes over what a catheter ablation is. We basically insert a catheter from the leg into the heart. In the heart, there's an atrium on the left side called the left atrium, and there are veins that enter the left atrium. And in the left atrium, we find where these veins are, and we apply energy called heat energy, that is, and sometimes thermal energy in the form of cold energy can be used as well. And so this is the way we've been doing this for a very long time, and this is our present-day technology. In this case, this is radio frequency ablation I'm showing you, and we basically encircle these veins with heat energy and stop the veins from firing atrial fibrillation. As I showed you previously, that's where the source of the problem comes from. Our most frequently used ablation technology up until now has been cryoballoon or radio frequency, both extremely effective, both have been our workhorse, so to speak, but both have possible risks that can be somewhat complicated, including phrenic nerve damage. These are the nerves that run from your brainstem to your diaphragm muscle that helps you breathe, and that can get damaged sometimes with these ablations. Also the esophagus. This is a common area that we are very much aware of that can potentially heat up or cool down very rapidly. And we're very mindful of this when we do an ablation. Both of these complications are rare. They can happen about 1% or quite less than that, sometimes even 0.5% of the time. I haven't personally had patients with this happen. We're very mindful of how we do this, but if it does occur, it could be a devastating problem. And because of that, the future, what is basically now, I would say even, but there's more to come. New technology has been available to us, and this is now frequently used. We are actually the largest center, I believe, as of today in the country doing this particular procedure called pulsed field ablation. We have been the forerunners. Inova Heart Vascular Institute, our electrophysiologists, in utilizing this technology in the country. And this is what we're doing nowadays. Pulse field ablation came about because of the safety considerations. This is basically nanopulse technology that is utilized to create electrical field across heart cells. And as you can see here in this cutout diagram, cells potentially have this ability to form fibrillatory signals that can enter into the left atrium, causing fibrillation. This particular technology causes something called electroporation. It disrupts the field of tissue around each cell and causes the cell to stop activating electricity. It's very specific to heart muscle, and that's the benefit of this particular procedure. In the slide, you can see we can titrate this to myocardium or muscle of your heart at 375 volts per centimeter. We can titrate it to any of these particular areas of interest, but if we titrate it to just muscle cell, we only affect muscle cell. As you can see, the nerves that run on either side of the heart in yellow are not affected by this, as they are not titrated to that level. And so what we found is that this is extremely safe, and safety, of course, is the most important aspect of everything we do when it comes to procedures. And as you can see here with radiofrequency energy on the left panel, there's a risk for damage to the phrenic nerve or the esophagus, and also with cryoballoon. But with pulsed field ablation, this doesn't seem to happen. There are many different varieties of catheter here. The upper right two catheters, the PulseSelect and Sphere 9, are what we use right now. And you can see this is what it looks like. This is the catheter gets entered in the heart. And this is compared to the thermal ablation technology, as you can see on the bottom, cryoballoon or radio frequency. What's important is that once we are in the heart, and this is a picture, a depiction of what it looks like, we use fluoroscopy to guide us into the left atrium and then into the left pulmonary vein or right pulmonary vein system. And in the bottom, we create a map in 3 dimensions in everybody. So this is your heart in 3 dimensions recreated in real time. It's called an electroanatomic map. We look at signals to see where the signals are firing from, signals that are coming from the veins. And you can see in the periphery, these are the veins here in the end. These signals basically are the areas of where atrial fibrillation emanates from and then enters into the heart, causing fibrillation. If we can stop the signals from firing, we can stop atrial fibrillation from occurring, and that's the benefit of this particular procedure of catheter ablation. This is a patient I ablated a few weeks ago at Inova Loudoun Hospital. We use pulse field ablation for this particular procedure. And on the top screen, I wanted to show you in your heart, what you see, everything that's blue, green, and yellow are high frequency electrical signals that we can see in our catheters. And I'll show you a slide of that in a second. But these areas between purple and blue, green, yellow are the areas where atrial fibrillation comes from. Everything that's red has no signal in it. We should not see any signals at the most distant part of the veins. These are the pulmonary veins, as you can see here, and this is the back part of your atrium. And on the bottom side, you can see what happens after the ablation. We've put all these ablation signals around here, and we've done a full ablation, and now there's no signal. Everything in red, as you can see up here, is less than 0.1 millivolts. That's no signal at all. We've basically stopped the dam from bursting, and this means that we've reduced the ability for the heart to have electrical signals that can cause atrial fibrillation. This is what it looks like inside your heart in real time. These catheters, as you can see in the bottom here, these coronary sinus or CS catheters, so high frequency signal. What you see in the middle, this very high voltage signal, is called pulsed field ablation. These are nanopulses coming at 4 pulses in a row. And by the 3rd pulse here, the signals are gone. And at the end, you can see there's no pulses at the end on the bottom of the screen. And this is all in real time. This took about 4 seconds to stop the signal from firing. But why is this important? Well, again, I said safety and now also efficacy we're finding extremely critical to what we do. Safety is front and foremost. And in the real world examples, we can see that we can reduce the risks of complications, as I told you before, between esophageal thermal injury and also phrenic nerve disease. But look at how much shorter the procedures become. And this is important because less catheter dwell time means less risk to our patients. So the shorter the procedures are, the better the outcomes are. And so procedural complications essentially reduce significantly post-procedure. There are no risks inside the left atrium. Procedural complications that we've seen so far are mostly just from anesthesia risks, which can happen to anybody, or even vascular risks that can happen with any catheter inserted into the body. So in summary here, PFA or pulsed field ablation is the newest technology to treat and prevent atrial fibrillation. Studies suggest it may be safer and more effective than radiofrequency and cryoballoon. And this, again, potentially can lead to shorter procedures and fewer complications. And so really a very important piece of technology that is available to us at Inova Heart and Vascular Institute at both Inova Loudoun, I should say, at also Inova Loudoun Hospital, Inova Fairfax Hospital, Inova Alexandria Hospital now. And we are literally the leaders of this in the country. We've done the most cases in the country so far to date, and that is because we have a robust group of electrophysiologists keen on providing the best options available for our patients. I wanted to spend some time here in the next few minutes as we get ready to close this talk about a very important part of electrophysiology and atrial fibrillation for that matter as well. And that is the patient, that is you, and that is how did you get to us and what can we do to help you get better and prevent atrial fibrillation despite us doing the best job we can. But what can you do if you are already living a life without atrial fibrillation to prevent it? Or if you've had atrial fibrillation and treated, how can you prevent the next event from happening? Well, first things first, the 5 domains of integrated care include rate and rhythm control, which we talked about. But there are a cadre of lifestyle changes that can be made to help reduce the risk of atrial fibrillation. We talked about a few of these already, but physical fitness is one of them. About 150 minutes of exercise a week is what we recommend. That's 30 minutes a day for at least 5 days a week. I think most of us should be able to do that. Utilizing lifestyle behavior modifications such as weight loss, diet, exercise, physical fitness, and activity, all have been shown to reduce the risk of cardiovascular disease, but also atrial fibrillation, whether you have it or not. Studies show that if you've had AFib and you embark upon this journey of lifestyle changes, you actually reduce your risk of atrial fibrillation continuing in your lifetime. We talked about stroke prevention, but oral anticoagulation is quite critical and important. We recommend and expect patients to be compliant with this because the risk of stroke is quite significant if you have several risk factors for stroke. And then lastly, of course, rate control. We always start with rate control first. We want to make sure your heart rate is under control. We recommend a resting heart rate, at least 80 beats per minute or less if possible, or a heart rate when you're active about 110 or 120 beats per minute or less if possible. And we talked about symptoms also. The quality of life piece is quite important. This is why our patients come to see us, because they have a reduction in their quality of life. And there's obviously a lot of options here in terms of medications, cardioversion, and we discussed catheter ablation as a potential option for atrial fibrillation management. So if we put all this together, this was an American College of Cardiology guidelines that just came out for atrial fibrillation this past year. And they made it clear to physicians that we need to really hit these 3 pillars to optimize our care. And that is stroke risk reduction, reducing all modifiable risk factors. And that, again, that includes if you're a smoker, you need to quit smoking. If you drink alcohol frequently, you need to cut down as much as possible. And if you have atrial fibrillation that is uncontrolled, we need to control it quickly with either a rhythm control approach or a rate control approach. Then we also discussed about risk factors and behavioral changes. If you look at all these risk factors in the bottom and do the best you can to modify these risk factors, even sleep apnea or getting good quality sleep, I would say, extremely important to reduce the risk of atrial fibrillation. If you're a smoker, you need to quit smoking. And if you don't exercise, you need to start to exercise as well. And so these are really fundamental changes that have come about in the last, I would say, almost 5 to 6 years. This is new. We didn't really spend a lot of time with our patients talking about risk factors. None of us went into electrophysiology to discuss or have to, remind people to go back to your doctors and talk about diabetes and hypertension. And we are here to take care of heart rhythm disorders, but we're finding more and more now that we need to help out with this as well. It's hard for primary care doctors to do this by themselves. And the more of us that talk about this, the better off I think we all can take care of our patients. And it's really important to hit home on this. And now we even have medicines, for example, for obesity that can help. In some of these drugs, there are studies that show if you take medicines to help reduce your weight, you actually have less atrial fibrillation as well. So there's a lot in the pipeline coming into this, but we have a lot of room to help improve risk factor reduction. So I wanted to make sure we spend time discussing this today. And so in closing, atrial fibrillation, our patients are in the center of all of this. We know that there are many pieces of this that have to come together for you to feel well. More importantly, we need to work closely with your cardiologist. Sometimes patients need to see a sleep doctor. We have a lot of times referred patients for sleep apnea evaluation. Sleep apnea is a common risk factor for atrial fibrillation, but we may even ask you to see a weight loss specialist if your weight has gone up significantly. This is important. Again, that also reduces risk of heart disease or cardiovascular outcomes. But we have to work very closely with your primary care doctor to help us with some of these things, because obviously an electrophysiologist can't do all of this by ourselves. And then sometimes I've also referred patients for behavioral medicine because anxiety can occur because of atrial fibrillation or depression. And these two things have also increased the risk of further atrial fibrillation in people. And so all of this in totality has to be utilized and considered when we take care of patients that have a heart rhythm disorder. And so it takes literally a community to optimize management of patients to help improve their outcomes when they have a heart rhythm disorder, and specifically in this case, atrial fibrillation. And I will also add atrial flutter is very similar to this too. We take care of both of those arrhythmias quite similarly, although they're distinct arrhythmias. And so I wanted to make sure everyone's aware of this, and you'll hear more about this, I think, in the coming years as more and more data comes out for this as well. And so with this, I will close, and I wanted to open this up for questions and discussion as well. And I'll stop sharing my screen here.
Wow, I'm out of breath just listening to you. You covered a huge amount of landscape there, and we have a lot of people here and a lot of questions. So first, I'm going to apologize because I'm not going to get to everyone's questions. I'm going to try to group these into topics and do the best I can. Chirag, you ended with risk reduction and the things that we need to do to help prevent episodes of atrial fibrillation. And you talked about sleep and sleep apnea being a newly recognized significant risk factor, as well as weight and weight loss. Is there any data now that any of the new weight loss drugs, the GLP-1s, have been effective in not just helping people reduce weight, improving their diabetes, and reducing cardiovascular disease, but also reducing episodes of atrial fibrillation?
Right. That's a really great question. This is one of the hottest areas of medicine right now. And we are finding more and more that there is a lot of good data coming out that we may be able to benefit patients with atrial fibrillation management with GLP-1 inhibitors. More recently, there's a study called the Transform Atrial Fibrillation Trial. It actually looked at this very question. And it said basically, listen, if you have a history of atrial fibrillation and you have obesity as well, and you take a GLP-1 inhibitor, there is a high likelihood that you may actually not only reduce your obesity, of course, but you may have less atrial fibrillation going forward, because we know this is a common risk factor. So there's a growing body of evidence that has come out recently showing that comprehensive metabolic management or obesity reduction tends to have a very high effect in terms of reduction of risk of atrial fibrillation going forward. We need more randomized trials to look at this, but this study just came out recently, and I think it's really a game changer in terms of how we look at atrial fibrillation.
Yeah, that's great, and that's very important. Let's switch over to triggers, because this is an area that I think knowledge has changed a little bit. You talked about alcohol. You talked about alcohol as a risk factor. How about other things like caffeine, decongestants, things that we think of as stimulants? Are they risk factors or triggers for atrial fibrillation?
All right, great question. We get this question all the time as well. I'll go back. Let's talk about, I think, coffee first and caffeine. This is a very common question. So we used to tell people years ago that caffeine, all forms of caffeine are bad for you. It's a stimulant, of course, and caffeine is going to raise your heart rate and it's going to make you jittery if you take too much of this. But it turns out the Arabica bean of what coffee comes from has a protective effect actually on reducing atrial fibrillation. It's the opposite of what we thought. And why is that? Well, if you're a coffee drinker, it turns out you're probably more likely to be active. You're less sedentary. You are more likely to maybe engage in exercise and have good habits in terms of smoking cessation or exercise capacity increase. And so caffeine from coffee beans actually protective. Don't stop drinking your cup of coffee. Now, what is not helpful necessarily are these large sports drinks that are loaded in caffeine and have other unfortunate stimulants in them as well that can cross your blood-brain barrier. Do not take those. But coffee, very helpful, especially black coffee, very good for you. I'm an avid coffee drinker. I love my coffee, a cup of coffee in the morning. And I will tell you, if you do the same, you're going to feel good too. Do not stop drinking your coffee.
Thank you for not taking away my coffee. I appreciate it. A question I think we always get, always, always, always. If someone's had a single episode of atrial fibrillation, a single episode, do they need to be on, and they have a CHA2DS2-VASc score of 2 or 3. They're a woman, 76 years old, have high blood pressure, single episode of atrial fibrillation. Are they now on lifelong anticoagulation?
It's a great question. Also, another common topic that comes up oftentimes. I actually have patients referred to me for this very issue because oftentimes cardiologists or primary care doctors are also wrangling with this. Now, I will tell you that, age matters, risk factors matter, comorbidities, other medical problems that you have matter a lot. And we look at all of those things. And there's something called a shared decision-making approach when it comes to this. We talk about this together. This is not a decision I want to make for you, nor do I want you to make this for yourself. This is a decision we both discuss in tandem. And there are pieces of technology you can use to help decide also whether or not you need long-term blood thinners. We mentioned watches or these mobile apps that you can actually measure atrial fibrillation. Now, if you have a low risk factor, and we mentioned those numbers before, the CHA2DS2-VASc score of 0 or 1, for sure you can stop your blood thinner. That's not necessary anymore. Your risk factor is very low. But if you're 2 or more, this is a nuanced discussion. We need to spend time in looking at the risk factors to see kind of what direction you go in, because if your risk factors are quite high, I actually may ask you to take this for an extended period of time, because those risk factors by themselves also increase your risk of atrial fibrillation. And so this is where those numbers matter. But if you're at 2, that's a gray area. This is sort of a very borderline sort of location of what we should do is not clear, but I'm going to ask my patient, I'm going to make sure my patient and I engage in this shared decision-making that we both either agree or disagree to continue the blood thinner.
People are pushing you on this caffeine thing. So now they're going, well, how about tea? Other forms of caffeine, that's not the Arabica bean. And so that is a stimulant.
Tea is a stimulant, and tea has not been shown necessarily to reduce the risk of stroke. And this has been looked at, or I should say atrial fibrillation and stroke for that matter. That's been looked at. And so tea is okay probably, but again, 1 or 2 cups of tea are not going to hurt you. We're talking about if you're taking mega doses of caffeine in any form is not safe. And so anything more than probably about 180 milligrams of caffeine a day is too much. And so, but still, if you want to be safe, drink coffee.
Okay, let me ask you a couple of quick answer questions so we can try to get through a bunch of these. So is ablation safe after coronary artery bypass surgery, after valve surgery, after a pacemaker, after a mechanical valve? Is it safe after other cardiac type interventions?
Let me do this in order. Yes, 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 yes. And I think the 5th one was yes as well. I think you asked 5.
Thank you.
They're all yeses. And so here's the thing, when we see patients in the office, we look at all of this, right? Our job is to make sure we have looked at the patient's history, look at their anatomy, making sure that we can do this safely for them. Just today, I did an ablation on a patient with bypass graft surgery at Loudoun Hospital and went beautifully, no problems at all. I've done patients ablations with mechanical valves in the mitral position or aortic position. That's been safe. We look at these things in a projection of, is at that time, that moment, the patient okay? Are they, functional? Are they healthy? Are they doing well? And if all those things are fine, this is a safe procedure. Now, if you come in and you have advanced heart failure, for example, and you're not feeling well, you're not breathing well, you have too much fluid in your lungs, we may hold off on that ablation, but I will still do it once you're optimized, right? And so that patient also benefits from atrial fibrillation ablation.
After ablation, how long should someone limit their activity?
Okay, so this is another great question, and this comes up often too. After ablation, we actually ask patients to kind of take it easy for the first 24 hours. That first 24 hours, I want anesthesia to be really washed out of your system. Your groin site's the most tender. All of our catheters are entered to the right femoral vein that's in your right groin or left groin site. This is susceptible to bleeding in those first 24 hours. You're actually back on your blood thinner that first 24 hours as well. That next 7 days, almost 7 days, sometimes 5 days, but it takes about 7 days for those insertions where we put that catheter in to heal. So don't go in a swimming pool the next day. Your groin is going to get infected. Take it easy. No heavy lifting, no heavy pushing, pulling, no more than I would tell patients usually a gallon of milk's worth of weight for about a week.
Someone asked a great question. No one's ever asked this question. Whoever you are, I'm really proud of you. They want to know, how do you get your catheters to the left atrium?
Okay.
How do you get there?
I don't know if you
That's a
remember that
great
video I
question.
showed before. There was a video I showed earlier here. The catheter is inserted through the right femoral or left femoral vein. We use ultrasound actually to make sure we localize a very region that we're interested in accessing. So it's quite a safe procedure. That catheter is advanced into your heart, and once we're in the right atrium, we then exchange that catheter for something called a transeptal catheter. And what that means is there's a wall between the right atrium and left atrium called the septum. The transeptal catheter actually has a little small wire in there, and that wire we can heat with radio frequency energy, and that wire then sends a heated impulse of energy to the septum. Tiny hole gets created. The catheter then goes through that hole into the left atrium. We advance a wire in there, and the catheter and the sheath now maneuver nicely in the left atrium. This is all done through a machine or a device called an intracardiac echo. You may have had an echocardiogram. That's where we put a probe on your chest and take pictures of your heart. This is an echo that we put in from your leg into your heart, and I can see your heart in real time in 2 dimensions, and I use that as a tool to get me from one side of your heart safely to the other side.
Beautiful. Real quickly, because I think this is an important question. Someone asked, hey, I heard that above a certain age, the risk of being on a blood thinner exceeds the benefit. Someone told me that if you're above 75, well, your risk of falling maybe is higher, so you shouldn't be on anticoagulants. You want to debunk this?
And that is a myth. And actually, it turns out that falling is not a risk factor to stop a blood thinner itself. Falling is generally not considered significant enough just to come off an anticoagulant. If you fell once and you were fine, that's okay. Now, if you fell and you had a brain bleed, for example, that's a different problem. We'd have to address that. And age has nothing to do with this. Age, I have a patient I just saw the other day who's 96 years old. She's on a blood thinner. Why? Because she has atrial fibrillation and she's in it all the time, and I don't want her to have a stroke. She's very safe with this. Our newer medicines, as I said earlier, are quite effective. They reduce the risk of bleeding and they reduce the risk of stroke very well. And this has been shown time and time again in both the elderly and the non-elderly.
Yeah.
So we are very
That's so,
safe with this.
yeah, that's so important, so important. And your risk of a debilitating stroke actually goes up with age. And so please, yeah, continue your blood thinners. Let's get into two somewhat, I'm not going to say controversial, but two areas that the pendulum has been moving. And I think you alluded to this. One is sort of our threshold for taking patients to the lab to do ablation as opposed to having them on medications. Let's start with that one. And then the second one I'm going to ask you is about Watchmen, so I'll just warn you. So, what I hear in the electrophysiology community is we're taking a lot more patients to do ablation. Let's just treat it, get rid of it. Let's not put you on these poisons or medications for long term. Let's not expose you to risks of atrial fibrillation, even if it's paroxysmal or on and off atrial fibrillation. What's your take on this? And what does the data tell us?
There's been a paradigm shift in our approach to atrial fibrillation in the last, I would say, 5 or 6 years again. And it's very interesting. A lot of data recently came out that suggested that we've been doing it sort of backwards for a long time. And why is that? Well, technology has really changed dramatically in the last 10 years, maybe 15 years, in our ability to safely perform an ablation and to provide very good outcomes. About 20 or 30 years ago, studies that were done looked at drug therapy mainly and not ablation therapy as the outcome measure in terms of reduction in the risk of atrial fibrillation. And then those studies showed that whether I keep you in AFib and just control your heart rate, or I give you a drug and cardiovert you and keep you in normal rhythm on a drug, that your outcomes were no different. You weren't going to be any better. And so a lot of us were just giving medicines to patients to control the heart rate. Now, with ablation, we found two important things. Not only can I reduce your mortality, this is a big deal. Not a lot of things in cardiovascular disease reduce mortality, but this does. And I can reduce your mortality, make you live longer, but I can also reduce your risk of heart failure. And these are in all patients that have atrial fibrillation. So there are two things in AFib that happen in the asymptomatic person. Let's say you have AFib and you don't know it, and you come and see me and say, listen, doc, I have AFib. I don't know it. I feel great. Why do I need to have a medicine or a catheter ablation or a treatment for this? Because I don't feel it. And I tell patients, it's just like arthritis in your knee. If you had an x-ray of your knee and your doctor said, listen, you've got really bad arthritis, you know what happens? Eventually that catches up with you. And eventually you start having knee pain. Just because you don't have it now doesn't mean you won't have it later. Eventually you may have heart failure. You may have valvular heart disease with asymptomatic atrial fibrillation. And what the studies show is the earlier we get to the disease substrate, the better your long-term outcomes are. Now, there's two caveats to this. If I see a patient and they've had even one episode, but it was symptomatic and significant of AFib, it is not unreasonable to move forward with an ablation instead of giving that person drugs the rest of their life. The caveat to the story is, though, the person that sees me, they've been in AFib for 10 years, okay? And they just got referred to me for AFib for the first time in 10 years. They've been in this for a long time. And I have to have an honest, conversation with them and tell them, listen, sir, I am sorry. I may not be able to keep you in normal rhythm despite my best efforts. The reason is atrial fibrillation is a progressive disease. Unfortunately, the more of this you have, the more of this you're going to have later on. It's hard to reverse something that is not beating well for years on end. And we can throw catheter and ablation and drug after you, and it won't work. And I don't want to waste a patient's time. So we may just keep that person in rate-controlled atrial fibrillation, perhaps.
A couple of questions about age. Is there an age cutoff for considering atrial fibrillation ablation?
No. I actually ablated a 86-year-old a few weeks ago. I will tell you what the cutoff is when it comes to age. It's not the number that matters to me. It's the person. It's you, it's the individual, it's your functional status, it's how active you are. This person was a spry 86 or 87-year-old. They looked like they were a 65-year-old. I mean, they're quite active. They're still bowling. They're playing tennis. These are the things that matter to me. The number isn't the issue. The issue is, how are you doing on a day-to-day basis? How active and how functional are you? Because it's the risk of recurrence of outcomes that have bad associated diseases that come out when you have a complication from this. It takes you much longer to recover if you're not functionally intact versus if you are functionally intact. So if something goes wrong, God forbid, with an ablation, you may not do very well if you're not very functional or if you're frail. But if you're not, you're going to do fine.
Something that I just want to make clear for folks, because there were some questions. You don't have to be in atrial fibrillation to have an ablation. So if you have on and off atrial fibrillation, our electrophysiologist will take you to the cath lab if you're in normal rhythm, because they will induce things and find the place where the atrial fibrillation is coming from. That's different than cardioversion, because people ask this question. We only do cardioversion to get you out of atrial fibrillation, but an ablation is a more definitive procedure. So just to clarify that. Right. Let's talk about Watchman for a minute, because this is another area that I think, the pendulum's swinging a little bit. People asked last question about ablation. Is it still considered experimental, and the insurance companies cover it?
It's definitely not experimental. And insurance companies definitely cover it. And as I said before, they used to not cover it unless we failed a drug first. Now we don't have to even do that anymore.
I think the question was on pulse wave. Is pulse wave still considered?
Yeah, pulse field ablation is covered. All ablations are covered. Pulse field is definitely covered, and it's covered as a first-line approach. We don't have to fail a drug anymore, again, in patients that are paroxysmal particularly, yes.
Great. Thank you for clarifying that. Let's go to Watchman, because, we actually just had a medical meeting last week, and we got into a long discussion about this. And, you talked about the indications for Watchman during your talk, but I think all of us see patients who come in and go, hey, I'm on anticoagulation because I've had atrial fibrillation, and, I don't have a lot of risk, but I really don't want to be on the anticoagulation. Can I get off of it? I just want to be off of it. I want to go skiing and not have to worry about things, or whatever it is. So So is that pendulum moving? Are we becoming more liberal with our indications for Watchman to allow people to get off anticoagulation? And then the corollary is it as good as anticoagulation at preventing events?
These are great, great questions and common questions we get a lot of. Let me start with the first question about the indications, and this is again a very nuanced question, and I'll tell you the pendulum is swinging on this. The CMS, Centers for Medicare Services, they're the ones that decide the reimbursement and whether or not things can be done safely by insurance companies to be reimbursed. They have come out and showed, and that slide is from the guidelines. That's from the 2024 guidelines, and it says on there that you have to have a contraindication to a blood thinner. Now, that is a very vague statement. If I said, listen, I don't want to be on a blood thinner, I don't feel comfortable, or I don't feel safe being on a blood thinner, that can be considered a contraindication in the right physician context. You have to have two doctors, however, signing off on this. Two separate doctors have to decide, both the electrophysiologist and either your cardiologist or your primary care doctor both say, for this person, we both feel a blood thinner is not safe, and therefore a Watchman device is not unreasonable. And so it could be as simple as that. And you don't have to show that you've had a bleeding complication. You don't have to show that you can't tolerate the medicine. You can just say, listen, I have two doctors that tell me that it is not good for me to be on a blood thinner, and you can go on and having a Watchman device, but those two physicians have to document that, and that's looked at very carefully. The second thing you want to say is there's something called a concomitant program now we're creating at Inova Heart and Vascular Institute, where we are going to start doing both Watchman implants and atrial fibrillation ablation at the same time, possibly. Now, it hasn't been fully approved by private payers, private insurance companies, but CMS has approved it. And so this is something to look for in the future. And so if a patient required a Watchman, let's say, it may be possible that they actually get an atrial fibrillation ablation at the same time. That has been shown to also substantially reduce the risk of stroke. But I want to make one thing very clear about Watchman. Not everybody benefits from this device. About 20% of people may still have the need to be on a blood thinner lifelong after a Watchman implant. And why is that? Well, there's two reasons for that. There could be a leak in where the Watchman was implanted, as you saw from that video I showed earlier, and that leak has to be just 5 millimeters or greater. We do serial imaging. If the leak is greater than 5 millimeters, unfortunately, guess what? If you couldn't be on a blood thinner before, now you're stuck on a blood thinner the rest of your life. And so that is a caveat to be aware of, and very, very important issue. The second thing is the Watchman device on this generation. Now, the next generation will be different, but this generation device has the potential possibility of having device-related thrombus. Thrombus is a clot. If the device is not well seated in the muscle of the tissue, and there is signs that there's a clot on your device, you just went from not having to take a blood thinner the rest of your life to taking a blood thinner the rest of your life, no matter what. So this is, again, a nuanced conversation. It requires shared decision-making. It is not straightforward, but I will tell you the next generation Watchman that's coming out, this is going to be a game changer, I think. And as a matter of fact, I don't even implant the Watchman device, but I think I'm going to get trained to do it because I see the technology emerging and evolving so fast that it makes sense that this is something that we should consider. I have not done Watchman devices because at this time, I'm not so sure. I was very skeptical of this because I've had patients that have had clots after the Watchman implant. And so more to come on this.
Thank you. And I think that was a very fair response. I'm going to apologize to someone. I meant to answer your question, but I erased your question. The question was, is Eliquis a good blood thinner? The answer is yes. Eliquis is a wonderful blood thinner. There are a couple of questions about AFib. Can it lead to heart failure? Can it lead to the heart weakening? And does it cause valve problems, or is it sort of the other way around? Valve problems can cause atrial fibrillation. We're down to the last couple of minutes here.
Okay, both things are true. Either way goes true. Now, I'll tell you, atrial fibrillation, high risk of having heart failure. Why? If people especially aren't aware of atrial fibrillation and their heart is racing, oftentimes they have a weakness of the left ventricular and right ventricular function, and this is a problem. And so one of the reasons of taking care of a patient that has atrial fibrillation that doesn't have symptoms is to prevent heart failure. And this is why we take care of them. We put them back in normal rhythm. Regarding valvular heart disease, it goes both ways. Atrial fibrillation by itself stretches the left atrium, and this causes a dilatation of the mitral valve apparatus, and that dilatation can cause regurgitation. The other corollary is true also. If you have mitral valve regurgitation, blood's going backwards to the atrium, and that atrial blood now is overwhelmed and your atrium starts dilating. And for both of these reasons, atrial fibrillation becomes more frequent.
So is that a contraindication anymore for ablation? Someone who's had chronic mitral regurgitation, I know I'm going to get a little medical here, and so their left atrium has dilated quite significantly. It's much bigger than normal. Are we still tackling ablation in those patients now?
The story matters. We have to do a little bit of crime scene investigation here. I need to find out what came first, the chicken or the egg. And I have to go back and look at their echoes and look at when they started atrial fibrillation and what really came first here. If they truly had mitral valve disease leading to atrial fibrillation, then we send this patient to our structural heart team and tell them, listen, we need to fix this mitral valve. And then I'll fix the atrial fibrillation ablation after, or do the ablation afterwards. But if they had, unfortunately, atrial fibrillation to begin with, and that's worsened, of course, yes, that's another reason that we need to go back in and fix the atrial fibrillation, because I can shrink the size of their valve just by shrinking the size of their atrium. And so both of those things are true.
Okay, one of our last questions. So I think we have some real fitness folks here in the audience tonight, which is wonderful. And some folks who are doing a lot of exercise. And I think you scared them a little with your U-shaped curve of exercise and risk. You know, when you're talking about too much exercise, can you define that a little bit better in terms of the kinds of things that we do?
Yes. You will hear these buzzwords in the literature these days called zone 2 training. This is where we need to be. Zone 2 has been shown to have the least amount of risk towards heart disease. And what does that mean? That's different for everybody, but that's a range of heart rates. And if you have an Apple Watch, it actually tells you where you are in your zone. You don't need to keep your heart rate at 180 beats per minute for 60 minutes on end. It does not help you at all. We use a calculation to determine what your age predicted maximum heart rate is. You can ask your doctor for that information, and you need to go to 85% of that. And that's all you need to do. Anything more than that, it's too much, and you will not actually get any benefit at all. It'll increase your risk of heart disease and atrial fibrillation.
All right, thank you. I get to back off a little bit now. Well, I'm going to thank Dr. Sandesara for giving us just an incredible evening of information and knowledge. It was just spectacular.